afternoon, everybody, and welcome to our pop-up ecosystem. This is the 6th in our series, and today's topic we'll be covering is the theme around mental health in COVID times. For those people who've not been to one of our pop-up ecosystems before, or any of our ecosystems for that matter, our ecosystems bring together all the stakeholders in health and social care to tackle regional health challenges. Now that's never more relevant with the crisis around COVID-19. Our ecosystems that you can see here bring together all the stakeholders to tackle and break down silos and also transform healthcare and create opportunity. And now these are multi-ecosystem. You can see how our ecosystem is growing. Certainly we've got many more ecosystems joining us and also taking part in these pop-ups. And soon to be added to that list that you can see in front of you now will be our latest ecosystem in Lithuania. Our pop-up ecosystems that we've got now, we've got a confirmed program which will include sessions that are targeting both Canada and Europe, dementia, which will be on June the 10th. And we're very excited to bring forward one targeting data donation and what's changed in COVID times. With the data donation one, we've also then got further pop-up ecosystems planned, targeting both matching supply, bringing forward an ecosystem event with our colleagues in Australia, further ecosystems, pop-up ecosystems targeting Latin America, and we hope after today, because of the amount of interest we've had, more targeting mental health and the issues around COVID-19. But we're also going to be looking to target regional pop-ups, as you can see in front of you, with our other ecosystems. These regional ecosystems bring us the opportunity to do both European and local level information. Today's topic, though, is on mental health. Many of you have seen a lot of press coverage around the impact on people's mental health, both in terms of stress and burnout for professionals in the health and social care sector, but also the increased levels of isolation, loneliness, anxiety and depression amongst individuals across the globe. This now means that we have hopefully today to start the series of looking at the topic of mental health. Today's panel we're really pleased to bring all our ecosystems together, including from Serbia, Scotland, our Brussels ecosystem, Northern Ireland and Northwest Coast, as well as our newest ecosystem in Canada from Montreal. And you'll see today's program features an exciting level of speakers. I'm going to now stop talking and bring on our speakers. The first we're going to go to is Michael Crilly and Jennifer Neff from Elemental. Over to you.
Thank you, Andy. Thank you. And hello, everybody. Hope everybody's keeping safe and well. I'm just going to show my screen here now and bring up our presentation. Let me just move this out of the way. Hopefully everyone can see that. So yeah, I'm speaking today all the way from sunny Derry, which is in the northwest of Ireland. It's a wonderful place, and it's the place where we set up Elemental. And Elemental is a tech for good company based here in Derry, but working all over the UK, Ireland, and soon to be in Canada and Portugal, which we're really excited about. And it was set up by myself and another girl called Leanne Monk. We're a team of 30 people here, and we genuinely care about the health and well-being, and we want to halt health inequalities in communities. We set Elemental up for 3 reasons, because if you have major things going on in your life, it's hard to look after yourself, your mental health and well-being and everything else. We also knew that there was so much support out there in people's communities in terms of help and programs and services and groups and things, but people didn't always know where it was and who was running it, and sometimes they needed a little bit more help to actually engage in it rather than just being handed a leaflet. It wasn't enough. And the other thing we knew from our community development days was the true impact of connecting people into these types of services that you see in front of you was not always fully appreciated by commissioners, and it really something needed to be done about it. So Leanne and I said, yeah, let's do something about this. What we didn't know at the time was that this was actually called social prescribing, and that what we were going to do was enable social prescribing to work better. So it was all around the better connection of people into their communities through the support of a link worker, a care navigator, a pathways advisor. There's a middle person in between the health and social care system and then the community and voluntary care system. And we wanted to be able to enable them to be able to support people into the different things that you can see here on my screen, the different types of support that's available. So we work all over the UK and Ireland, as I say, and it's all really about helping people to access better mental health, feel less isolated, be more physically active, to age well and to stay well in their homes for longer. So we work across all these different sectors and all these different places, and it's amazing because every project is different, and it really depends on the nature of the community and what the community needs help with. So that's a little summary of what we do. How do we do this? So we enable people to either make self-referrals through to a link worker, social prescriber, community connector. So you can either, if you had a hotline number and someone was concerned about their neighbour or their relatives, it could be done through Elemental. A GP or a social worker or an occupational therapist or a paramedic might be concerned about someone, and they can make a referral as well for someone, or else someone can self-refer themselves through a council website or a charity website. And what they do is they use Elemental, then the link workers, to be able to understand what's important to the person, what they're interested in, and then they share with them a whole range of different things that are available in that person's local community. And that person can then choose the different things, like a walking group. Maybe they need help with debt advice. Maybe there's some bereavement support that they need. So there's lots of different things that they're connected into. And we track and measure and we monitor the difference that it's made to the person. So it's all based around referring them, connecting people in, taking some baseline metrics, and then supporting people in, creating a plan. And the person's very much part of that plan because they've had a choice in what they want to do, and then measuring the difference. And then just finally, then before we can see some of these great examples in action with Michael Crowley, I'm just going to talk finally about measuring the impact, because we know that when someone's connected into their community, they feel better, they're less anxious, they're less depressed, and their well-being is improved. So we made sure that we were able to capture that and report on that, and on what's the impact on the person, then what's the impact on the community, the voluntary sector. Lots of great things happening there. Let's show how much of a demand the walking group is for, and the difference that the walking group and maybe the local men's shed has had on the person's well-being. And then finally, what's the impact on the health and care system? So are we seeing less GP appointments as a result of this? Are there less accident and emergency appointments and readmissions? What's the difference in the actual system itself? So I'm going to hand over now just to Michael, and before I hand over, Michael Crowley and Mercy Care NHS Foundation Trust really bought into what our idea was and our concept was many years ago. And we've been on a journey together, and I just want to thank Michael and his team for believing in Elemental and for sharing today how they've been using Elemental. So over to you, Michael.
And thanks, Jennifer. That's a lovely introduction as well, and a lovely way to describe the partnership, because it has absolutely been a partnership, as I hope you're going to see. So it's great to be here with you in this strange world that we're currently in. As Jennifer said, I'm a director at Mercy Care NHS Foundation Trust, which is one of the largest mental health National Health Service trusts in England, with the full range of mental health services. And I guess if I were to simply describe the bits that I have any responsibility for, it would be what we kind of talk about, the life beyond diagnosis. So there's a recognition in mental health services that for many people, they may live with the enduring realities of a mental health condition for the rest of their lives. But in our trust, we believe passionately and fundamentally that no diagnosis should ever define a person. You are a unique human being, an individual, precious for that human dignity, and you have a right to life. So often in mental health services, people exist, they don't live. And we undertook a very extensive listening program about 6 years ago now, out with our service users to try and ascertain the things that got in the way of their recovery journey and got in the way of them staying well and staying out of formal services. And what came through loud and clear were very much the kinds of things that Jennifer's just been talking about in her slides. It was the social issues, you know, housing, debt, financial matters, social isolation. They weren't the clinical issues. And that set us on a fairly fantastic journey over the last 7 years to try and better understand our responsibility as a healthcare provider to really look at the social determinants of poor mental ill health. And that led us to establishing something called the Life Rooms. And you can see 3 pretty pictures on the slide there in front of you of our first 3 Life Room bases. So we decided to take a bit of a shift away from conventional clinical services and to establish small localized hubs at the heart of individual communities, particularly communities of the highest levels of social deprivation and need. So the very first one we set up in there, you can see on the left, was a beautiful Victorian library built in the north of the city of Liverpool. Second one, a gorgeous shop front building in the heart of a small town further up the coast from Liverpool called Southport. And then the third one, which you see on the right, was a brand new build, state-of-the-art building in the Liverpool Dockland areas, Bootle. And since then, we've established further locations in the heart of a theatre and health centres, and on and on and on. And our ambition has always been to try and be a cog within the heart of a community that enables a community to engender the relationships they need to keep themselves healthy. We know the community is of its essence healthy. And that began the Life Rooms journey. If we could just go on to the next slide. You begin to see here, I'm not going to bore you by going through all of these policy indicators, but you can see on the left there that there is now in the UK a real emphasis on social health. So the kind of thinking that's out there now in policy documents is beautifully starting to mirror what our service users were telling us 6 and 7 years ago, that it was the social issues that really had the greatest impact on their mental health and well-being. And it's really interesting to see the state begin to catch up with people on the sharp end and their lived experience of society. So you'll see there's a much bigger focus now on people actually being able to prevent the impact of mental distress. And this is a really important concept that fascinates me in the time of COVID, in that much of the conversation that people are having about mental health and COVID at the moment is about crisis. It's about supporting people once the impact has happened. That's kind of not what people tell us they need. And it's not really where the policy in this country is now going. It's about prevention. And that's a core feature for us in our Life Rooms developments. And in particular, within those policy factors, you'll see there's much more of an emphasis on the individual themselves, on their own power to be activated around their health, to manage their mental health conditions in particular, and to actually ensure that they don't have that almost inevitable descent into crisis services. So there's a real solid policy background now to social approaches in mental health, which I thought was useful to share. The next slide there is really the core purpose behind the Life Rooms model. And this set of principles co-produced with the people who access our services. And broadly speaking, these are the things we exist for. So to raise the profile of mental well-being, empower service users within the community, not within clinical services, but within the places that they actually live, and contribute towards ending the stigma that surrounds poor mental health. Those of you who are connected to mental health in general will know that there's still a phenomenal amount of stigma that surrounds people with a mental health condition. People are maybe beginning to get used to depression and anxiety, but still the more serious end of mental health is often regarded with suspicion. And by locating our units within the heart of communities, we really sought to break down some of that stigma that exists. Promote well-being through non-clinical opportunities. So everything we do in the Life Rooms is non-clinical. You know, I have never in my 11 years in mental health met anybody who's woken up with a burning desire to access clinical services. You know, clinical services are important when we need them, but actually they're not the destination. the destination for people with a mental health condition, like it is for any of us, is a life that is purposeful, rich, meaningful, and of choosing. We exist to improve access to meaningful occupation or employment opportunities. That's really, really key. So many of our people suffer massively from the health inequalities that go with poverty. So income maximization is important, but actually even more important again is giving people the tools, skills, and the confidence to begin to care for their own financial well-being and their family's needs. And we contribute to a stronger community through partnerships. This is absolutely where our digital partnership with Elemental has become absolutely key. Very often, statutory state-run services are effectively dominating the local ecosystem. This is much more about recognizing the partnerships that need to exist within our communities in order to deliver a different kind of health service. So why is it the NHS that's doing this? It's the NHS's job to be a health service, but so often in this country we've become a national illness treatment service. We only respond in times of crisis, and as we're seeing right now, we do a brilliant job at responding in times of crisis. But actually, if we're about health, then we've got to be in the prevention game. And the ability to actually create an infrastructure alongside Elemental that is both physical and digital is really beginning to help create a situation where the voluntary community sector in this country can begin to participate in the things that we do in the local health and ecosystem. And they participate as full partners, networked in such a way that creates a seamless pathway of care for service users who don't then need to worry about the politics and the dynamics and that can often exist around a health economy. So we can have the next slide, please, Jen. Those are the things that the Life Frames offers. It's a multiplicity of well-being offers. I'm not going to go through them all now. That's just there to show you what and who we are. In particular, it's the social prescribing bit, what we call the pathways advice, that I want to share a little about now. And I think that's been an incredibly powerful tool in general for us over the last 3 to 4 years. But what we've discovered now in a COVID world is that actually it's kind of been the key preventative offer that stops us automatically defaulting into a system that only deals with crisis, the stuff I alluded to a few minutes ago. So what we've been doing very rapidly with Elemental is we've been taking our digital platform, we've been creating over the phone video conferencing support to individuals who are now dealing with the practical realities of COVID-19. And we've been using Elemental to speed people through to that community partnership that exists around us, so that straight away the issues that are beginning to cause people a huge amount of struggle are being addressed. So many of those actually won't in the first instance be mental health related. So we will be able to connect with people, and we've now connected with over 2,500 people in the last 5 weeks. That's pretty phenomenal by anybody's estimation, to really begin to address the social issues. People are worried about their food, they're worried about their shopping, and they're worried about those practical issues. Well, if those aren't addressed, they can really result in heightened anxiety and a fall into potential crisis services. So by being able to work proactively with our patients in this way, we're able to head off a lot of potential clinical need. But one of the things that is really surfacing from this proactive approach has been a massive issue around anxiety, depression, social isolation. People are not only afraid of the health impact of COVID, they are absolutely petrified of the potential impact in the future. So loss of jobs, livelihood, how do I make the finances work? To be honest, while the rest of the world has been focused upon the physical health pandemic, we have been very much preparing for what we would describe as the second pandemic, and that's the mental health impact of COVID-19. And by being able to work in this digital way with the partnership with Elemental and the voluntary community sector, we feel as though we're able to head off some of that impact. There will always be people who need clinical intervention, but we're beginning to head some of this off. Sorry, just the slide that was on a minute ago. Sorry, Jennifer.
Brilliant, thank you.
Coming into land, the impact of this is measured in terms of impact to systems, individuals and communities. And on that slide, you can see some of the impact that we have around there. But in particular, I want to point out in relation to this, and while I'm talking, we can move to the next slide, is that we are beginning to measure an impact to clinical costs by working in this way. So it's not just a nice thing to wrap around people. By working with people in this proactive way, we can begin to change outcomes, change journeys for people, and reduce costs, which is quite remarkable. The second pandemic we've already talked about. Where the partnership is situated now is about creating much smaller secondary mental health services and creating bigger preventative approaches to people. And ultimately, we would seek to grow this model, not just in COVID-19 times, but for normal mental health business. Thank you so much for listening.
Thank you very much for that. Very, very interesting presentation, and really, really good to see a practical implementation of the Elemental platform, specifically around mental health. And as someone from that background myself, it's I can only endorse the impact this has in terms of supporting people and preventing episodes from becoming threatening. Now then, one of the nice things about the input there from Elemental and Michael is we can connect the dots up here. And one of the nice things about our ecosystems is that's a common theme. And there's a connection now between Elemental, and we'll come on to later on, our colleagues in Scotland, because Elemental as well have a very, very large presence in Scotland with their Spring social prescribing platform. So it's good to be able to connect the dots. Just as quickly, we can connect the dots now, because I'm really, really proud and pleased to introduce David, who's an advisor for what will be shortly our latest Montreal digital health ecosystem. From Techno Montreal. So David, over to you. Thank you very much.
Adam, thank you very much, and good morning, everyone. My name is David Gobey-Kaufman. I'm based in Montreal, in Quebec, in Canada. So it's in morning, 7:22, and we're pleased to be to be here with you. So just want to be sure that you see my screen now. Adam, can you confirm that you see my screen?
You see.
Super, thank you so much. So yeah, so I have the chance to be advisor. Oh, I don't see my screen anymore. Okay, let me find it. Excellent. So I have the chance to be advisor at Techno Montreal, which is a technology cluster, which the mission to mobilize technology industry players around growth generating projects led by the industry. So been founded in 2007, and originally the objective is to promoting the industry of the IT, through governments and creating a community of companies that can work together through projects. And through the year, we realized how it was important to focus our work on human being, which was centric to our initiatives. And so in the past year, the organization created Humanitech, which is a think tank, which have the mission to answer the question how IT or technology can we place human at the center to create technology that are useful for communities. And so basically we launch studies to find the potential impacts of their technologies in order to help people understand how technology can help them through their lives and enhance their lives. And so we are implementing projects in order to do so. So for our project, and we understand that today is mostly about mental health, so we'll focus on that. And so I will mostly talk of the first project, which is called Aging Well at Home, which basically the project is how technology can improve the quality of life of Quebec seniors. So the objective is to maintain autonomy in the environment chosen by the elderly person, and basically pushing back institutionalization, which we believe is very important in order to keep elderly happy, through their lives. And so if we go in this time of crisis, just before the COVID, one thing good to know about our ecosystem is that, you know, tech ecosystem in Montreal is thriving, is very dynamic, multi-generational. So Techno Montreal is mostly, you know, representing middle-sized companies, but the startup ecosystem is thriving too. And so for the last year, we saw, you know, governments trying to put a position in order to help founders of companies through their mental health challenges. As the, you know, couple of numbers, Canadian data indicates that 30% of business considered that emerging technology or startups fail because of emotional turmoil experienced by their founders. You know, burnouts and in their challenge to you know, they have lost their side goals. And so that was already a subject that was very important to the ecosystems. Projects been launched in a couple of months just before COVID, and obviously COVID just pushed these subjects in the middle of the scene. And so as a cluster, we were asking ourselves, how can we help our members to go through this crisis, which is you know, which is awful. And so we launched a survey, and we creating roundtables. And we're trying to understand what were their needs at that time. And the question that we're asking, you know, that I've been asking was like, how do I keep my mental healthy, right? But also like a lot of other aspects of their business that were putting pressure on their mental health too. Like, you know, how do I keep my team happy remotely? You know, how can do I manage my cash flow? Was a huge challenge during this, and still is. Do I need to pivot my business model, which is like for any entrepreneur, is when you were already in the business model and you need to change it, you know, some of them are ready for it, but some of them don't. How do I feel about asking for help? And this vulnerability aspect it's key for what we are talking about. Is that basically the question we were asking ourselves are, what are the critical elements of human-centered leadership that could be useful for our members to go through this crisis, and hopefully creating tools in order to go further the crisis and create a new culture through their organization and through our ecosystem. So we didn't revolution anything. We just came back to basic and designed a project called Leader Circle. The Leader Circle objective was, you know, first of all, and it's reducing the impact of isolation. And for the one, you know, for the one who know entrepreneurship, you know that, you know, being an entrepreneur is very isolated. You know, you need to live through challenges that you're the only one who know exactly the amount of challenge that you get, and being able to have other entrepreneurs to help you go through it and sharing informations and you know, advice. It's a very strong tools. So we are, through this initiative, we also want to nurture a culture of sharing and being able to help entrepreneurs to connect with others and to give advice one another. We also want to offer access to, you know, the best experts as possible through different, you know, psychology, leadership, and so forth. Other entrepreneurs with a great path, with great value, with great experience, that can come and share their experience. That will help for sure. Also, you know, we saw through the years, in the tech ecosystems, we see, you know, criteria of success as growth and hyper growth some of the time. And I think that we are, as an ecosystem, we realize how unsustainable it is. And at the end of the day, if entrepreneurs are not able to you know, to be stable and to be confident and to be happy, you know, growth is just secondary. And so I think that the crisis just accelerate this consciousness about it, because we saw, you know, I think that all business, but it just, at some point, you know, it's a little futile when you know, we need to rethink about family and employees and how to keep people, you know, on board and happy and safe. So I think that this crisis is an opportunity to help entrepreneurs to get a sense of having new tools in order to go through this crisis and after. So basically, this whole initiative is to promoting a human-centered leadership, and also other initiative that we believe is important is creating bridge between generations. As you know, some entrepreneurs have experience to share, new entrepreneurs have new dynamic and new energy to share. And we believe that this circle is going to be a great opportunity. It's a good opportunity to create those bonding between generations. And also for the one in Quebec, it's a very large territory. We had a lot of regions. It takes hours, 10 hours from north to south to go from Montreal to Gaspésie, for example. So distance is the real issue when it's time to create bonding between ecosystems and between entrepreneurs. And technology is a great opportunity in this case to break down those boundaries and creating bridges. So we're very happy that this initiative will be proposed to all entrepreneurs around Quebec in IT through our ecosystem. So it's, the format is pretty simple. First of all, the most important thing is safe space. We offer a group that's gonna stay 8 to 12 entrepreneurs that are gonna stay together for 8 weeks. So that way we'll be able to nurture the relationship, digging deeper, being able to talk with things that usually will be maybe more taboo. So safe space is the first and most important thing. Also, all cohorts, all programming will be co-created with the participants. So that way we're going to be sure to tackle the challenge that they have at that point in time. And in this crisis, I've been doing some circle for the past months, and the challenges are changing every week. And as Michael said it earlier, we realized pretty early on that mental health will be the second pandemic for sure. And so having an opportunity to bring entrepreneurs open, obviously, to discuss about those topics together and having an open-minded discussion about entrepreneurship, leadership, and mental health first and foremost will hopefully be a strong tool in order to get them through this challenge and building some tools for after. So the project's for 8 weeks per cohort, per group. It will be a 90 minutes per meeting. We will have one expert invited per circle and one moderator from our team to get the discussion going. And I'm very curious to have your thoughts about this project. So please write to me at the end of the presentation if you have any advice to give. We're very open to hear it. So we are launching the project right away. So if there's any companies from IT, from Quebec interested by this project, please subscribe on the link on the presentation. Thank you so much for your time.
Thank you for that, David. Very, very interesting and completely relevant to the issues our ecosystems are facing. It's also good to know and to hear from Canada. As I said, as I mentioned right at the beginning, our next pop-up ecosystem will be featuring and co-run with Techno Montreal. So we're proud to be bringing into the fold of our international network a brand new ecosystem in Montreal and Quebec. And thanks to David for giving us a little bit of a flavour of that. As I said just now, it's time to join the dots again, and we go from David. Thank you very much. To Brussels, and what's the connection between Quebec and Brussels, as well as the linguistic connection? Very, very strong presence and interest from our Brussels ecosystem in connecting up with our new potential ecosystem in Canada. So, Anouk, over to you.
Hi. So I'm Anouk Process for PSYSOLIDAIRES.org. Thanks and good morning, everybody. I'm pleased to be with you. So I'm a psychologist and I created PSYSOLIDAIRES.org at the beginning of the quarantine on the 19 March 2020. PSYSOLIDAIRES is a Belgian initiative aimed at French-speaking populations set up to respond to the distress associated with the coronavirus measure and its effects. And the measure put in place by the government to stop the spread of the coronavirus have an impact on isolated people, distraught families, and caregivers were required to do intense work. And in the situation, it has also been proven that old trauma re-emerge and behavioral problems can worsen, like anxiety, post-traumatic disorder, depression, suicidal behavior, addictive behavior, domestic violence. And a study by the UCL Louvain shows that 52% of Belgians express deep discomfort as a result of this pandemic. Other studies also show that it's likely to affect the people's mental health. And for instance, there has been 9% increase in the consumption of drugs. So our objective with PSYSOLIDAIRES creation was to reduce people's distress related to the confinement.
So during the last few months, Anu created a website to support people and as well as health workers by providing active listening sessions by psychologists. In total, 201 psychologists registered to support our response, and currently, as life is starting to get back to normal, we still have around 100 psychologists active and motivated to continue this effort. The psychologists are from different backgrounds. We work with clinical psychologists, psychoanalysts, psychologists special for children, adolescent, parenthood, and couple, as well as work psychologists and cognitive psychologists. We had a lot of students who registered. They were terminating the master degree this year, but that we decided to be sure to respect the legal framework of France and Belgium, to don't work directly with them, but to work in another way with them. As you can see on the diagrams, PSYSOLIDAIRES is a multi-country association. We have psychologists based in 5 countries right now. 75% of them are based in France, including 2% living in the island. 23% of them are based in Belgium and 2 of them in Canada, Switzerland, and Jordan. All of them are French speakers, but some have specific language skills and can provide active listening sessions in different languages as English, Spanish, German, Hebrew, or Arab. Hello.
So I created the platform and a team has been formed over time. We are all psychologists with complementary background. Manon Leflour, who is with me today, works on the monitoring and in evaluation. Lucie Yvon on the ethical framework. Laetitia gives supervision and training to the all volunteer psychologists. And Twiggy is in charge of the all staff recruitment. And PSYSOLIDAIRES is using a humanist approach centered on the here and now, and we guarantee to our beneficiaries respect for the following fundamental principles like listening, empathy, communication, support, respect, confidentiality, and humanism. And we ask our psychologists to agree and to sign our value on the chart. So how are we working? So beneficiaries fill in a form on the PSYSOLIDAIRES website, and my team analyzes the request and finds the most suitable psychologist for each profile. Depending on the localization, speciality, availability, and as soon as we have confirmation from the psychologists, we make the connection between them both. And after each active listening session, we kindly ask all people to fill in a feedback form.
So what's happened the last few months? We started to work on monitoring and evaluation 2-3 weeks ago, and we are still processing some data. So today we will mainly discuss about March and April. But in total, we receive around 500 forms, so requests from the website that we process. As you can see on the graph, 78% of the requests have been made by women and only 18% by men. We notice that men tend to ask for help when they are in deep distress, while women ask for it more easily. It is interesting to note that we can see a peak of men requests at the end of April, so pretty far after the confinement measure. About the age, we see a bigger proportion of persons aged between 18 and 35 years old, 59%, as you can see, and as well it's people aged between 36 to 60 years old. Only 3% of the requests have been done by a minor, mainly parents asking for support for their children or by adolescents having access to internet over 15 years old. We worked obviously on the process to support minors to be sure to link with framework and legal aspect. And the last repartition is 5% of the requests have been made by people over 60 years old. It's pretty low, but it's probably explained by the use of digital platform and tools. In fact, most of the requests we have from this specific age proportion, it's made by younger family members or caregiver. As mentioned, we receive around 500 forms, but this graph is only about March and April. So we received 386 forms requesting support, and you can see the type of the request. It's 3 different kinds of requests due to COVID-19 difficulties, other requests, or I am a healthcare worker and I have difficulties. So you can see in March that there is most of the requests was for people struggling with COVID-19 situation, but in April we can see a change for the demand. Most of the demand was for other categories. And this trend is like reinforced in May right now. What was the major distress sign? Because when they fill the form, they can have like the small summary about what's going on, like that. It's easier for us to dispatch like the request to the perfect match with a psychologist. And we have, from that, we have been able to identify these 6 types of distress. So most of them was anxiety due to the situation or reinforced by the situation. The other categories that was difficulty with families and children, loneliness, conflict and violence, depression, and personal problem. What we did with that? So from these 308 requests, we have been able to have some data, and as you can see on the graph, 66% of them have been referred to one of our psychologists for some active listening session, between 1 to 3 according to the therapist. 33% of them, they have been referred to adapted structure or services, and 1%, it's like one case that I've been able to reconnect with the old pathway. Oops, sorry. So the data shows that there is a demand of mental health care and the necessity to facilitate access. The COVID-19 crisis unfortunately strengthened the distress, but people were most of the time referring to all difficulties. The comments and the discussion with psychologists during supervision showed that going through an online platform could be easier than calling directly a mental health professional. We all know that it could be a step forward to understand the field of mental health care. To take a phone and to take an appointment can be difficult. Anouk?
So we also asked in the feedback form to advise on whether the listening support helped them or not. And so far, 85% told us yes, that helped them. So there's feedbacks, and the growing number of requests have shown us the positive impact on people in need. The feedbacks also tell us that in most cases, the first listening can diffuse the accentuation of harmful behavior for the individual. So after 1 to 3 active listening sessions, around 30% of the beneficiaries continue or are redirected for specific therapy that correspond to their needs afterwards.
So as we saw just before, we got like around like 200 requests. Others are not like directly linked to COVID-19. So it's highlighting the need that there is a necessity to continue PSYSOLIDAIRES. And that's why we are here today to confirm our intention to go forward. We worked with the team on the logical framework with a general objective to promote mental health well-being and a specific objective to facilitate access to mental health care. In purpose to have 3 results: provide punctual support or active listening session between 1 to 3, refer people in mental distress to competent services, and as well to be an anchor for anyone seeking help.
So concretely, we are aiming to continue to work with our 100 volunteer psychologists, select for their common value of mutual aid and solidarity, to organize psychologist supervision every 2 weeks and potential trainings, provide 1 to 3 active listening sessions offered by our volunteer psychologists, and create an online referencing containing a maximum of volunteer psychologists, partner psychologists, and institution and structure. So if necessary, reorientation of beneficiaries to adapted services. So PSYSOLIDAIRES aims to cover all French-speaking European countries as Belgium, France, and Switzerland. And yes, to make the service last, I would like to develop the platform, and I'm therefore looking for funds and financial support. So we need more visibility to generate more requests via social network, digital marketing, more volunteer and partner psychologists also to help more people, develop an online directory referencing, including a network of psychologists who provide face-to-face therapy in all regions of French-speaking countries, and automation of various tools like agenda appointment services, and at least internet telecommunication respecting GDPR. So thank you for your listening, and if you have questions, we are available after. Thank you.
Merci beaucoup. Thank you very much, both of you. It's very, very interesting. Very, very interesting to hear that, and a unique service and solution you provided there. And you've given me a lovely connection to connect up the dots to our next speaker, who is right now, I believe, although he's from Serbia, are you Nicola sat in Switzerland? Is that correct?
Yes. Actually, I and my colleagues. Can you hear me?
Yes, we can.
Hello. Okay, here I am. So actually, yeah, I'm working as a radiation oncologist and clinical informatician in Switzerland, in Bern. But I'm involved in this nice initiative, Doctors for Doctors, or Doktori za Doktore, in Serbia. So I will try to confine on this 5 minutes limit to explain what is actually this about. Doctors for Doctors is an initiative started by multinational, multidisciplinary team. Multinational because we are affiliated with different universities in Europe and around the world, like Rotterdam, Milan, Bern, Belgrade. But we are practically also originally from Serbia. We have recognized the need early on to address this special issue of mental health, especially in this, let's say, vulnerable population of healthcare workers. And because of that, we have started this initiative at the first place. Their initiative consists of approximately 20 different specialists. Myself, I'm a radiation oncologist, actually, in medical informaticians, but we have also specialists of occupational medicine, psychologists, psychiatrists, specialists of public health, and other disciplines. We are really multidisciplinary team. So at first, I will explain why had we reacted, why have we came together at the first place. As I have already explained, we are like multidisciplinary team from multiple institutions around Europe, and based on this experience that our colleagues had made, especially in Italy, we have recognized this need to address this special issue of mental health of healthcare workers and quality of life during COVID crisis. And as you may see on this nice graphic there, I have to admit this is not our authorship, but I have found it on internet. But it represents very nicely what may be expected in the time to came, because this first wave, if you see here, is mainly oriented toward the patient, and this mortality and morbidity caused by COVID-19 at first couple of months, as we already know, is mostly connected with direct infections. But as we can see right now, the second wave of mortality and morbidity will be mostly from the people that didn't receive proper care in proper time, like cancer patient, other chronic conditions, diabetes, heart diseases, and so on. And what is also most important during these couple of months of the crisis, significant burden of mental health issues had developed, and they were not properly addressed, as we can see from our early analysis and early results of our initiative. And we have been prepared to address those issues that are going to last, that are going to be there for a longer period of time. And that is especially this issue of mental health and mental problems. And right now I'm going to explain really shortly how this initiative works and how we are actually acting. On the next slide, there is only like schematic representation of our workflow. Our main program consists of a scheduler and a set of different questionnaires and data report forms that are based on some psychological tools and psychological evaluation tools, such as depression, anxiety, and stress scale that consists of 21 items that help healthcare workers, psychiatrists, and psychologists to evaluate acute stress level, depression, and anxiety in affected person. Then we have used also a different kind of standardized questionnaires for evaluation of stress on a working place, for evaluation of stress at home, to evaluation of the psychological conditions outside work, and also we have used a couple of tools and questionnaires for evaluation of working condition protection and COVID status in healthcare workers that are mostly affected at COVID hospitals, but also in other hospitals that are not directly involved, such as children's hospital or oncological hospital and other healthcare institutions. So what we have achieved is direct connection with several major hospitals in Belgrade. This is the capital of Serbia, where we have started a proper clinical trial according to all ethical and legal norms. We have separated this in several phases. Currently, we have a second phase running on, where we are expecting around, let's say, 100 to 120 physicians that will enter this prospective evaluation in form of this longitudinal questionnaires, and some basic results will be known already in a couple of weeks, and then we are going to evaluate this, discuss, and present as soon as we finish this process. Basically, we have a possibility, as far as I know, we are the first in Europe that are doing such longitudinal evaluation of this complex issue from multi-perspective of working conditions, family conditions, community condition, and mental health status all at once. My 5 minutes are already gone, and I will be happy to answer all questions that you may ask. So thank you very much for your time. I hope that I was understandable.
Thank you very much for that. Very, very interesting and a unique approach that we're very keen to follow, and I'm sure there'll be people who will want to contact yourself following your presentation today. I'm going to move on swiftly now because I'm conscious of your time, and I know you're away for another meeting now. But we're going to move without any hesitation to Novi Sad to introduce Igor. Igor, if you could show your video, please, and we'll move on to your presentation, please. Thank you very much. Thank you, Nicola.
Okay.
Thank you. So,
could you see me?
Yes. Yes, Nicola, you just need to turn your camera off, Nicola. And yes, we can see you, Igor. All yours.
And I need help with the presentation.
That's okay.
Okay. First of all, I would like to thank you. Thank you all for the opportunity to present my I would like to introduce myself as well. So I'm the local SeedStars ambassador. SeedStars World is the largest startup network for startups in emerging markets. And my job in SeedStars is to get startups which already have MVP and who haven't raised more than $100,000. I'm also teaching assistant at Faculty of Technical Science, where I'm mostly participate in subjects concerning entrepreneurship and technologies. I'm also Chinese Alibaba partner, which is also startup competition, similar like SeedStars, but only for startups in early stage. All of these references help get nominated to be a part of team, which was established by the government of Republic Serbia, by the Cabinet of Minister of Innovation and Technology. This is a team of experts created to develop innovative as a response to COVID-19. Apart from evaluating the ideas of other people, I had few of my own, and one of them is supporting people who need help from psychotherapists. Next slide. Okay, the idea, I'm going to talk about a web application that was developed in just 7 days. The goal was to get up and running as a simplest solution to reach the market. So what was the idea? The idea of the web application was to do release with the MVP at the earliest, because due to the restriction of the move in the Republic of Serbia, we were aware of the fact that the number of anxiety and depression causes would increase, so we want to help the people in need. At the same time, we partnered up with the Serbian Association of Societies of Psychotherapists, which put us in contact with more than 400 psychotherapists who do their job on voluntary basis. This currently make it us like a largest network of psychotherapists in whole our region. Next slide. Okay. The idea itself, it's fairly simple. We made it so the users are completely anonymous and that they only need 3 clicks to reach a therapist. So the users click on the user button, get a list of the available appointments, and then they can make an appointment at the time of they choosing. After making appointment, the appointment is saved in their 1 hour before the appointment. They get notification to remind them that they have appointment. Next slide. From the angle of the therapists, it indicated because we made some special restrictions so that only certificated therapists can apply using a special code. This code can only be given by the presidency of the Serbian Societies of Psychotherapists. After entering the code, the therapists can start to log in. They enter their personal and contact information, current occupation, how many years of psychotherapy education have passed, which therapist model they use, and where they get their certificate. After logging, they can put in the times where they are able, so the users can choose where to make an appointment. When they finish a session, the therapist fill out a survey that we use for our statistic analysis, which give us data on what were the reasons they use and what we can do better on the app and better for them. Next slide. Okay, so now we get into the statistics we have so far. Statistic data show that the current total number of therapists are more than 400, which I mentioned before. The current total number of appointments made is around. The only worrying thing in this in that over 60% of appointments were cancelled. Although Serbia is a country with a low level of awareness about mental health, maybe this number should encourage us in sense that it is raising awareness about this issue and showing people that they can find help. That they can find help if they're needed. Next slide. I think thing that we noticed when we talk about the COVID situation is that every time we were in the media, the number of users drastically increased. So considering that, we are considering situation that we are doing all of this on voluntary basis, and that we didn't have any financial support for marketing or support to create this app. We realized that with some investments, which could help us to promote this app via marketing channels, we could reach a significant number of users and at the same time raise public awareness about the importance of mental health. Because next slide, the last one actually. Next, the last one. Because this is web application, our idea is to create mobile app which will be more complex in sense that it will have, for example, matching options where people can choose a therapist most suited to them. For example, if someone is adolescent, they would get a therapist specialized in that field. If the users are healthcare workers facing a lot of stress, they would be matching with therapists with more experience. And for the end, we are able to translate this app into any language in just a few days. If you believe that this app is applicable in your country, you can contact me via LinkedIn, and that's it. I'm finished. Thank you.
Thank you very much for that, Igor. Very, very interesting and interesting to see.
I was very fast.
Deployment. So that's our contribution from Serbia. We're going to move very, very swiftly now over to out of Serbia and fly all the way over to Scotland. We're going to hear from Chris Wright, who works for the Scottish Government. Chris.
Thank you. Just give me a second here, just organise myself. I hope you can all see my presentation and can hear me clearly. I will try and speak slowly, but as you can hear from my relatively thick accent, I am from Scotland, which means as one of the native English speakers, I am the least understandable. For me, I am the digital mental health advisor within Scottish Government. This is a relatively recent post that I took up in January. I've been involved in the implementation of technologies in mental health since about 2003, so I've been doing this for a fair length of time. What I'm going to do today is just explain a little bit about the work that we are doing nationally across Scotland to really support the efforts of our psychology colleagues and mental health colleagues who are currently attempting to deliver services within this current situation. I think it's important that we realise that there's been a real shift within the government's thinking in Scotland to focus on technology as a way of now delivering services across mental health, but also a way of supporting our health and care staff moving forward. And this is primarily due to the expected increase in demand. As I think it's been mentioned a few times, we're expecting demand to go up exponentially in the next few months. But we're also aware that key staff have been redeployed into other roles within our health and care systems. And I think in addition to that is now the emergence of new conditions that are showing high levels of prevalence, such as health anxiety and social anxiety. For us, though, we've taken a relatively strategic approach to the implementation of digital within mental health at this time. We're looking at the short-term needs for COVID, but equal to that, we've also looked and ensured that anything that we're doing also has long-term applications within mental health. We focus on three key areas: digital therapy, which focuses on things like CCBT, internet-enabled CBT, which I'll touch upon later on, and other means of delivering face-to-face therapy through digital. In addition to that, we focus on online self-management and self-care, as well as video conferencing aspects in terms of delivery of groups and face-to-face therapy. One final aspect of this, though, has been the rapid assessment of digital products and potential solutions. Some of you will be aware that there's a lot of digital applications, solutions and products that exists within mental health, and it's been important during this time to really assess very, very quickly the needs, the fit, but also the evidence base of a lot of these products that could be used. Just moving back a few years, it's important to realise that in Scotland we've actually had a digital mental health programme for a number of years, the key focus of which was our computerised CBT services. We now have computerised CBT existing across the whole of Scotland. This was started in 2007, would you believe, where we had 11% of our population and 2 CCBT services in our Forth Valley and Tayside regions. In 2015, we then expanded to about 44% of the national population, and in 2018, we completed a national rollout of CCBT. The significance of this was a huge element of that work was actually working with clinicians, patients, and others to improve acceptability of digital within the mental health areas within Scotland. And you can see here, we started round about the national population around about 2014. At that time, we were only receiving about 1,200 referrals, and systematically over the last 4 or 5 years, we've increased to be a large mental health service within Scotland. But what I wanted to emphasise is that the work was not focused on the implementation of a specific technology, but rather development of platforms of service. And what this effectively means is we have in our 14 territorial health boards the ability to integrate additional products, additional service, and deliver it using the same governance and managerial structures. What this enables us to do is to move away from a slow implementation model, which could take up to 2 years to establish services, into a very rapid deployment approach. What that's enabled us to do as a response to COVID is then to rapidly expand our CCBT services. So these are now expanding from what was a depression and anxiety service into offering treatments across social anxiety, health anxiety, stress, resilience, and sleep problems. In addition to that, we're also adding additional capacity around long-term conditions and the mental health consequence of those conditions. And those treatments now cover diabetes, chronic heart disease, respiratory conditions, multiple sclerosis, rheumatoid arthritis, and diabetes. So we're going from what is a relatively restricted, small condition-based treatment into something much, much larger and covering a range of priority areas such as health and social anxiety, but also then building for the future moving forward. In addition to that, we've also introduced a test of change program for CCBT, which then allows us to test new treatments for young people and perinatal in the first instance, but moving on into other modes of delivery into areas such as prisons, for example, moving forward. The expectation of this is actually we'll more than double the size of CCBT in the next couple of years, with potentially up to about 29,000 additional referrals. In addition to that, we are looking at introducing a new service called Internet-enabled CBT. So we've had Internet-enabled CBT running in Scotland across 3 of our health boards for the last 12 months, but only in a small contained fashion through test of change. What Internet-enabled CBT allows us to do is to put people directly in contact with CBT therapists, but through written communication. So that is CBT delivered through the written word as opposed to face-to-face. The key advantages of this technology is that we're able to deliver CBT therapy into the most remote and rural areas of Scotland, which has a number of technical issues around delivering through other technical means or in a face-to-face traditional model. So it allows us to overcome a lot of our geographical barriers within Scotland, but also a lot of our staff shortage barriers in these remote and rural areas. These treatments will be made available across the whole of Scotland, and it's envisaged that we'll have a pot of treatments, as it were, which then can be moved into areas where we know that the greatest demand as a consequence of COVID exists, and really support the psychological therapy services moving forward. As an example of how powerful this technology can be, we rolled internet-enabled CBT out in NHS Western Isles, which some of you might know is an incredibly remote and rural area of Scotland, right at the north, and it's made up of a series of islands, and it can be islands that have literally handfuls of people living on them. When we introduced the internet-enabled CBT approach in Western Isles, we had a self-referral approach, and you can see there as a population of 23,000 people in total, we've actually received 350 self-referrals. This is about 5 times bigger than the actual psychology service within Western Isles. So an incredibly popular option, but also showed that we were able to really reach populations who have had no prior service. In addition to this, we've then rapidly rolled out our video enhanced therapy services. So this is telepsychiatry and telepsychology integrated directly into existing services. So this is the principle that you're now delivering via video enabled technologies, but as a part of an integrated approach. So these are not separate clinics, these are integrated into existing clinics. We deliver this through our Attend Anywhere national platform, which enables point-to-point communication. So in theory, patients will be working at homes with therapists who could also deliver this from home. It's supported by a national implementation program, and we support the rapid deployment of the technology, but also driving up usage through communications and marketing strategies. In addition to that, we provide national guidance, which then enables and supports the implementation within clinical settings. So this is addressing the many questions and concerns, and hopefully provide reassurance around the use, particularly within a psychiatry setting. You can see there in week 4, which was at the beginning of March, we started the national implementation in earnest. We had 137 clinics running and about 712 consultations a week. And that's rapidly increased in 6 weeks to 3,103 consultations last week. In addition to this, we also have a self-help and self-management approach. So we work with our national supplier, NHS Inform, which is a national website in Scotland, to develop interactive psychological self-help guides. These are interactive guides that people can complete online and covers a range of conditions from things like stress, sleep problems, anxiety, depression. And we're really focusing on key areas such as post-traumatic stress and bereavement and accelerated those programs. And this is how it works. So we have a step care model within Scotland, and most of our services will also maintain and develop and deliver services in a step care approach. So we've been very thoughtful in relation to the strategy we've taken and how we are delivering services across step care. You can see here at the mild to moderate prevention end, we'll have self-help, followed by CCBT, followed by internet-enabled CBT at a more moderate to severe level, and then obviously video-enabled therapy sitting within psychiatry and psychology services. What we're doing currently is we're enhancing a lot of these services with the addition of other technologies such as apps, particularly prevalent in services such as eating disorders. So you can imagine that we're now able to allow patients to remotely record weights and various other information that's required within clinics, and to digitally share that into clinicians who are then able to consult with patients through video technologies. One of the other kind of key strands of our strategy is to be supporting staff. So what we've done is we've taken a very systematic and joined up approach to supporting staff. All our support covers all health, care, care home staff, and other areas such as prison staff. What we have currently available is local telephone support, which is provided by our psychology services, psychological first aid, which deals with the practicalities of mental well-being, access to treatment programs such as CCBT, but we also have specific digital training now around COVID and management of patients, as well as the additional self-help resources. This has only really been made possible by a huge partnership network that we have, which covers government, local health and care suppliers, as well as third sector and primary care. Now, what's been important about this process is really a process of shared and defined responsibility. So we have clearly defined clinical responsibilities, clearly defined technical expertise, and clearly defined marketing and implementation expertise, which all feeds into the partnership approach. And what this is really designed to do is to really maximize the impact of the work we do by ensuring that those that should be carrying out the work do so. But I think the only reason the partnership really works is we build a common set of goals and aims across the whole of Scotland. We spend time to really learn about our partners and our partnerships. We develop a clear understanding of the capabilities, but also the restrictions and limitations of partners in terms of resource. But we also are responsive, trusting, and willing to share and be transparent. And that's all I have to say. Thank you very much.
Thanks very much for that, Chris. I think that's a fascinating example, yet again, of rapid deployment using existing digital solutions in a really exciting and innovative way from Scotland, and gives us a very clear link now to introduce what's now our Highlands and Islands ecosystem. And I'm pleased to introduce Mark Grindle, who's going to talk about digital storytelling as a route to resilience. Mark, lovely, your camera's on. We've got a presentation coming. And can we hear you?
Hello.
Thanks very much.
Is that everything working okay? Yeah. Okay. Well, thanks for having us along here today. It is a great opportunity to be lined up with some other brilliant speakers, and actually a lot of innovation going on there, and there's certainly connections that can be made. So I want to talk around some work we've been doing at UHI. So my role is as a senior researcher in digital health at University of Highlands Islands at the Institute for Health Research and Innovation, and particularly sit within the sorry, I think my video's gone off. Can you still see?
Yes, we can still see you.
Okay, yeah. Sit within the Department of Rural Health and Wellbeing. I just want to talk a little bit about, as I say, some of the work we've been doing in relation to mental health more broadly in a rural context, and more recently, specifically, using digital storytelling as a route to resilience in frontline staff, hospital and care home staff during COVID-19. Sorry. Okay, I'll start by talking a little bit about what we're doing and with whom, what our digital storytelling approach to increasing resilience is and where it came from, a little bit of background there, and then some evidence for the approach, just by pointing to some cases where it has been used to increase resilience across a range of communicable and non-communicable diseases. And then I want to point to a study we're doing internationally that uses the potential of digital storytelling to reduce resilience to CV-19 in remote and rural regions of low to middle income countries. And out of that, I will hopefully issue a brazen call for any international collaborators to get involved, because we are having to turn what was a current study into helping young people with mental health issues in low and middle income countries using digital narrative to helping them during COVID, because obviously now that's what we're seeing is that's where it's showing great impact. Okay, so what we're doing and with whom, we've just been funded by the Scottish Scientist Office and we're launching and designing and testing a smartphone intervention using our approach to increase mental health resilience in frontline NHS and social care staff. We're focusing on the resilience to situations and triggers that lead to fear, anxiety, depression, insomnia, low self-esteem, and indeed isolation. The triggers we've identified we're going to be focused on are the fears arising from risk of coronavirus through exposure to infected patients, the lack of personal protective equipment, the risk of infecting loved ones, isolation from loved ones, working around the clock, belonging to ethnic and socio-economic groups who are most vulnerable, and those who have underlying conditions. That's going to be the focus of the narrative. Now, I just need to now explain a little bit where this all came from and why on earth would we use storytelling to improve mental health resilience. So I should explain that my background is in film, television, and computer games industry as a screenwriter, script editor, producer, and executive producer. My background isn't in health, though I've been involved in health research since 2014. It was while working in Hollywood, it was quite clear that there were active ingredients within audiovisual narratives that are used to engage emotionally across national boundaries. And it became quite apparent that those cluster of ingredients could be tested, and indeed they certainly showed that when we started to run health stories in series like Dr. Finlay and High Road and in children's dramas at the BBC, that we would be using these approaches. We would find people calling back to us, said that really helped us support us, that really brought us close together. A narrative around male breast cancer. My husband has felt so isolated and stigmatized. And it was these responses that really started to suggest that we should be using these strategies a little bit more in health. But it was working in the computer games industry that became quite apparent that when someone is immersed in interactive entertainment, they see the character that they're playing, even though it's a third-person representation of a character on a screen, they refer to them in the first person. So there's this illusion where that seemed to happen, where patients and the public could use these technologies and use a narrative to try out new behaviors and experience new emotions, and leading them towards adopting new health behaviors, very much focusing on the emotions. It's an interdisciplinary approach we use, and it's backed up with evidence of neuroscience and psychology and evolutionary psychology, and also draws in from commercial marketing as well. In essence, our approach is we're using to increase resilience. It blends all commercial, audiovisual, and interactive narrative strategies then with behaviour change theories, behaviour change techniques, and key messages that's pertinent to the particular health outcome we're concerned with. One critical component of it is that we start by working with the target group. It's often referred to as PPI, public patient involvement, but we've extended this now because we're interested in their story. We're interested in their feelings and how they would help somebody like them. And it seemed to be that during this process that there was actually a sense of empowerment, a sense of belonging that actually seemed to be an active ingredient. Okay, just going to the next slide now. So the idea is that we can create non-threatening, non-judgmental and safe spaces, but by using virtual reality to tell the narratives and mixed reality, we actually blend real world environments with the virtual world environments. And as we're seeing now through COVID, this is clearly something which the public and patients are much more ready to embrace out of necessity, but it's not going to go away. We've used this approach to in cardiovascular disease to motivate patients. We've used it in cystic fibrosis to I'm sorry, there's a mistake there. We've used it in cystic fibrosis to increase adherence to chest physiotherapy. That in the case of a film, we've used it in mobile applications and SMS to reduce binge drinking, and we've used it in tobacco cessation to increase mental health resilience and increase smoking cessation in pregnant young women. I just want to dive into one of the case studies now in which we've used this approach, just to explain why we're confident that it hits the parts of the interventions can't reach. The Game of Stones intervention was funded by NIHR. That used this digital narrative approach to engage and increase resilience in obese adult males, and to motivate weight loss through improved diet and increased exercise. Now, you know, the focus there is clearly lose weight through diet and increased exercise. So the idea was we engage them, we motivate them towards that. But what the narrative allowed us to do, now these are the characters that featured. What the narrative allowed us to do is to take over 12 months, take those participants by using SMS on a journey of this character who's called Slim, and to take them on his journey from being diagnosed with type 2 to the point where he's able to change his lifestyle and reverse type 2. Now, again, the focus typically might be, well, you're overweight, eat less, move more. Those are clearly the key messages. But what the participants were able to experience was his life, his world, his low self-esteem, his problems at home with his wife because of his weight, the lack of physical component in his life. So, you know, he's advised by his GP to eat less, move more. But what it takes is him to address his friendship with Budge, who for him life is the new fat is the new black. And for his Mike to befriend him, get him involved in the community, so he becomes motivated. So certainly they learn new behavior change techniques along the way, but the idea is by engaging emotionally with character story, that participants were able to take on board messages that were more diffuse, but because they're emotional, potentially more powerful. That project, yes, they lost weight. But what was most interesting about it was the number of participants who sent text back to Slim, saying that what new behaviours they'd adopted, what they were doing, how they felt about what they were doing. So rather than a normal intervention where it's just directional, it opened up a space where conversations could happen around how he became resilient to the triggers in his environment, at home, in the community, and his low self-esteem and his stigma, how he's able to overcome that, and therefore adopt a new lifestyle that allowed him to lose weight and move more. Okay, so we've used the approach, same approach, to create a digital platform to engage adolescents, working with Health and Social Care Alliance Scotland and Highland Children and Young People's Forum. And as I say, just to close off on this project, it's called Wildlife. Now, Wildlife uses virtual reality and social virtual reality to tell a story of Molly, who has the power to transform into wild animals. Now, the idea is that by engaging young people in remote and rural locations, with this intervention and developing it with them, they can see their lives in a new way, and in a non-threatening way, and in a safe way, and and particularly a non-judgmental way. Nobody's telling them what to do. Nobody's telling them to change their behavior. They're just having an experience that along the way they pick up the skills. Now, here's some of our stakeholders in Myanmar. I won't point to any particular individuals, but numerous of these children are orphans. 2 or 3 of them had their homes burned down literally 3 weeks before, and to see their empowerment, to see them be able to look at their lives in new ways, was so encouraging that we've now extended the argument for more funding, and now we're extending this out into in South Africa, Myanmar, India, Colombia, and Brazil. But obviously travel has stopped us doing it, so we're taking the advantage of using online technology now to work with young people in these areas. And as I say, Brazil's one of those. As we see what's happening in Brazil with COVID, there is a real need for this, and we do need to get as many people involved or advising, whether they be government officials, whether they be narrative storytellers, whether they be musicians, and indeed whether they care. Okay, so that's me. Thanks for listening.
Thank you for that, Mark. Very interesting and a completely different approach, and I think one, as you say, is looking for international cooperation. International cooperation and collaboration is what we do, and this is entirely the point of these pop-up ecosystems. I would advise you very strongly, Mark, briefly to listen out for and get engaged with our Latin American ecosystem events, which are coming up soon. We can catch up offline about that. I just think, just with the picture in front of us here, just to close off from today, and we'll come back to some Q&As in a session. Let's just look back briefly. This pop-up ecosystem is entirely around connecting up the dots. And if you wanted a unique look at as many different ecosystems as you can in one day, how many ecosystems can we squeeze into a pop-up ecosystem for 90 minutes? Well, we've managed 8, and I think that's a fantastic tour across some of our new, emerging, and also well-established ecosystems. So thank you, firstly, all the speakers. I would personally, obviously we've kind of run out of time again for Q&As, but I would personally like to thank the contributions from all of our ecosystems and our members. I think today what we've seen is a renewed focus on mental health, and specifically a focus that's around prevention, a focus that is around trying to use more of our existing services better. And I think we've seen an existing, a really good use of existing tools such as the social prescribing, both in Liverpool, in Merseyside, and in Scotland, as well as new approaches in Belgium, so and Serbia as well. So thank you for those as well. I would just like to formally thank everyone for taking part in today. This session has been recorded, and we'll be busy in the next day or so chopping this up and serving this up for people who want to listen to this online. For my part, I'd like to thank all our speakers and wish you well, and I hope to see you at our next ecosystem event, which will be on June the 3rd, where we're linking up with our brand new ecosystem in Canada, at Montreal, with the Techno Montreal people. Thank you very much. Goodbye.